Hello, everybody. Greetings from Confederation of Medical Association of Asia and Oceania. I am Dr. K.K. Agarwal. This is our 42nd non-stop meeting. And today we will talk about will new mutations will affect our
See,
working.
camera is off.
So we will be talking about will the new mutations will affect the vaccination program or the molecular diagnostics. So the subject we are discussing is, will the new mutations will affect our diagnosis or our mutations? So I will go slow so that more people can join, and I will show you some of the slides for that. So whenever you see a second peak, so whenever you see a second peak, so whenever you, let me come back to the slides, spotlight, stop video. How do I make it up? So that my pictures are up and my slides are down. How do I do it, Ritu? Stop video, rename spotlight, add profile.
Presentation mode में on कीजिए.
Which one?
Presentation mode. So you can just next click.
So I will make it off, then I will make it gallery, speaker view, gallery view. Then I go to share screen. When I say share screen, I want all the photographs to be up. I'm not getting that. Okay. So in the remote new share participation, more, then I go to participants, Mayank Agarwal, security, stop video, new participants, pause share, remote control, more. Anyway, I've not been able to go.
I'm trying to.
I want it so that I can see everybody on the top. Meeting info, hide. There used to be pause, new share, invite participants list. Anyway, whatever it is. So when we talk about this, so whenever you see, how will you suspect a mutation first? Either you are getting a second peak in the society, as happened in UK and South Africa. Either you are seeing a second peak in the society, suddenly you find your molecular diagnostic tests are not affecting. For example, your S gene test is showing abnormal report. So S gene is showing abnormal report, or there is a second peak, or the plasma or monoclonal antibodies are not working, or your vaccine failure is there. So whenever you get these things in the society, you start suspecting that there is a mutation in the society. So if you say in this particular patients now monoclonal antibodies have stopped working, plasma therapy has stopped working, vaccines are not giving results, or there is a high viral load in the RT-PCR test in the society, suddenly you start getting high viral loads, or your one of the genes stops functioning in the RT-PCR test. You started getting a lot of false negative RT-PCR test. This is how you suspect that there is a mutation occurring in the society. Now, to understand that, we will go back to the main understanding of the virus. If you can see, these are the amino acids. And if you see top SARS-CoV and bottom MERS-CoV, both of them are almost the same, except for in SARS, we have 1,255 amino acids. In MERS, we had 1,353 amino acids. That means it has 98 extra amino acids in MERS which got deleted. That means all the amino acids which were dealing with seriousness got deleted from MERS. So one thing is clear, every time a virus mutates, number of deletions will be there. For example, in the UK strain, there are 3 deletions. So this 1255 will become 1252. So every time there is a deletion, the infectivity may reduce. The mortality may reduce in these particular cases. Now we need to understand there is a protein called NSP14. This is called as a NSP14 non-structural protein 14, which is responsible for proofreading of a mutation. If NSP14 is lost, proofreading will become defective and a mutation will occur. So, and a mutation will occur whenever you have a proofreading mechanism. So therefore, whichever medicine kills NSP14 will increase the mutation. So NSP14 is a part of RDRP, which is so if there is a mutation in RDRP, NSP14, if gets mutated, if there is a mutation on NSP14, then the proofreading mechanism will be lost. Then this virus will become like a virus of flu, and it will be highly mutable virus. So at this moment, misuse of remdesivir and favipiravir and plasma therapy. Misuse means you are giving it in an immunocompromised person after 7 days. In such a situation, you may end up into further mutations, which I will give you the proofs. Now let us see a couple. I want to be slow. Now there are more than thousands of mutations have occurred, but only few mutations have settled as a survival of fittest. L means the original Wuhan sequence, then became S, which were in 84th amino acid. So every time you see here, there will be 84th amino acid means between 13th and 318th amino acid. VG, we will fix ourselves to the current locations here. We will fix ourselves to the current locations here. And that is the current virus all over the world is D614G. G for glycine, D for aspartic acid. That means originally at 614 amino acid, there was a D amino acid, which has been replaced by a G amino acid. Let us see where is this 614. 614 is in spike protein, S1 subunit after RBD. Now this is important. Any mutation in RBD is significant. Any mutation in RBM which is the main key portion of RBD, is further significant. Now, this mutation is 614, that means 510 and 679. Therefore, this is the current virus where the main effect is 614. So this virus is likely to mutate further because every virus would like to enter and take a control of RBM or RBD. So all viruses wants to take over the control of RBD and RBM so they can open the lock easily and enter inside the cell. So there every mutation which will occur to reach towards RBD and RBM. So this virus has come back to this location, or see, either it will go on the right side or on the left side. If the mutation occurs on the right side, that is 679 mutation. So 679 mutation is the most important because that is serine peptidase, the cleavage area between S1 and S2. The virus cleaves. So therefore, either it unlocks or it cleaves. This is transmembrane entry and this is ACE2 entry. So any mutation occurring on this side, green, red, or 679 will be dangerous. So as on today, the virus had 614G mutation and he is looking for opportunities. So opportunities are given by NSP14. So whenever NSP14 gets destroyed, the virus would like to have a mutation to enter RBM, RBD, or 679. Now let's see one by one. Nigeria. So Nigeria gave a mutation called 681 from P to H. P means proline, H means histidine. So instead of proline, it made a histidine. Where is this 681? This is at the 679. So this becomes a virus favorable mutation, 681. So this is a virus favorable mutation, but this is an individual mutation. It has not yet made an association. Like we have CMAAO association of 19 medical associations. So we are stronger than individual association. So this 670, 681 in Nigeria is a single mutation occurring at 681, but it has not formed a federation of all the associations. So therefore, Nigeria strain fizzled out. Nigeria strain fizzled out. But let me go back to 614G again. 614G increases coronavirus replication and infectivity, but it was also making germ more vulnerable to neutralization by antibodies, which the virus doesn't want. Why this 614G wanted to mutate? Because it was getting neutralized by the antibodies. So therefore, 614G cannot lie, it has to mutate. And that's what it is occurring now. It had to mutate. So the Nigeria model is the virus has mutated in Nigeria and come to know, yes, we can have an association with 681. So 681 was identified by the virus that if we make an association of viruses together, we will include 681. Then there was a virus which came in A4 in India, which fizzled out. But now came a virus in India called 440K. There is a virus going on in India, which is 440. That means at 440 location, asparagine has been replaced by lysine. Now, where is 440? Oh my God, this is in the RBM. So this is very important. But so far, UK virus has ignored India. He says, I don't want you for the time being. But if this 440 goes into the UK virus will become more prevalent and it will become more contagious. So this virus is there already in Andhra Pradesh, Karnataka, Maharashtra, Telangana, and one reinfection has been confirmed. So 440 is an important mutation for future. But this is alone. So alone, one country, one virus cannot do anything, but this is important. Then there are two more variations in Kerala in India, but both of them are different. You can see this is C1240. That means on the extreme CP part of the spike protein. Second is 84, very near, insignificant. Nobody will bother to, if the Kerala virus says, I want to enter into a group of viruses, they will say, we don't need you. Then Australia, there is a 477 strain in Australia. This 477 is again in the RBM like in India. So therefore, all the people who have made an association will start looking for an option. We take 440 from India or 477 from Australia. If this enters into, it will become further serious. The care comes is a cluster 5 mutation which came from Denmark. So in a Denmark, there was a cluster of viruses where the most important thing was deletion of 69 and 70. Deletion of 69 and 70. Now, two amino acid at 69 and 70. Whenever there is a deletion, the virus will change its structure. And whenever there is a change in structure, molecular diagnosis will not be able to identify it. Monoclonal antibodies will not work. Plasma therapy may not work. Now, this 6970 in cluster 5 in Denmark made the false negative in RT-PCR. If you say your RT-PCR is false negative, and if you say in RT-PCR S gene is target failure, you take it for granted there is a 6970. Now this virus got killed out in Denmark because this was a solo 6970 deficiency, others were insignificant. So therefore it was available for a association, so UK adopted it. So UK virus adopted the Neisseria 681 and 6970 deletion from Denmark ended up into a conspiracy with 681, and both of them mixed together. So therefore 6970 entered into the concerned UK one. So what happens in the UK? You have 6970 deletion, and then you have 681H from Nigeria, and then it adopted a new one called 501Y. Now this 501Y, let me come back from where it came. Now 501, let me come back, then I'll go back. Yes. So 501 came from a immunocompromised patient. So there was a immunocompromised patient persistently infected with COVID, acquired approximately 10 mutations in the spike protein over 148 days with N501Y. So there are references that whenever you misuse medicines, N501Y, which is N501Y, can form. Now, what happened here is, now it adopted, there was a 23 different parties with various mutations. They joined hand and made a UK virus with 23 different types of viruses. The important one becomes N501Y, which came because of deletion of, which became because of NSP14 damage. Then there was a deletion of 6970, which came from cluster 5 of Denmark. And then 681 came from the Nigeria one. So all of them they make a UK virus called with 23 different mutations. These three are important. All 20 are also important, but these three became important. You can see mutations on the right side. Everywhere there are mutations. Now this has These mutations have 4 deletions. In 20 out of 23, 4 deletions, 269, 70, and 2 more. That means this virus is going to change the way antibodies work, the way vaccines may work, and the way molecular diagnostics will change. And then it has 13 non-synonymous mutations, which means the variants of concern with that. And then there are so many. I'm only talking about those which are clinically identified to be of concern. Otherwise, there are so many types of mutations in this 23 mutations. So how to diagnose UK strain by existing RT-PCR technology? If you do, the patient will show all gene positive, but S gene will be negative. So in your country, if you find, and if you say my patient is having S gene negative, other genes are positive, this is the UK strain because of 6970 deletion. And UK strain is causing more cases in age group 7 to 11. Now, these are the areas. Now, there is another deletion in UK edition, which is called 145 deletion. So they are saying this may be the one which is responsible for neutralizing antibodies. That means in this strain, neutralizing antibodies may not form or plasma therapy may not work. So these are the different mutations. Now we come back to South Africa. Now this South Africa, we have with us the chairperson of South Africa Medical Association who participated with me. She is right here, Anjali, and she gave me some of the slides which I am using. South Africa is again 501, the same which is there in England. But South Africa has 2 more mutation, 417, which is in the RBD, and 484, which is in the RBM. That means South Africa strain is more dangerous than the UK. And if these 2 viruses decides together to make a single virus, it will be deadly. So the next mutation will be UK virus getting mutated, acquiring or taking over the South Africa virus, or taking over the Australia virus, or taking over the Andhra Pradesh virus. So the next mutation we expect is, because in the UK virus, even today, we don't have a RBM moiety mutation. So UK virus has 23 mutation, which is the largest mutation. Therefore, if they acquire RBM mutation, that means 484 from South Africa, or 440 from India, or 477 from Australia, it becomes a further deadly virus. This is the slide given to me by them, which shows that majority of the cases in South Africa are new strains. And now we come back to what happens in South African 3 mutations. 501 increases your binding affinity to ACE2, but 484 and 417, they absolutely confers resistance to antibodies. These are called neutralizing antibodies, class 1 and class 2, which are dependent on up and down movement of the RBD of the RBD, and that movement may change. Therefore, these 2. So therefore, whenever we have a RBM type of a mutation, monoclonal antibodies affection will occur. And therefore, if the UK one either takes 484 or 417 or both, or 440 from India or 477 from Australia, it will be a disaster in future. Now this is South Africa, which is clearly showing early peak. And this is what I meant NSP4. This is what I want NSP4. In a cell, RNA-dependent RNA polymerase, a part of that is NSP non-structural protein 14, whose job is to proofread. If this protein becomes dead, or is neutralized, mutations will occur. Misuse of antiviral drugs when not needed. If you develop resistance of the antiviral drugs, remember, as there is a bacterial resistance, there is also a viral resistance to antivirals. If that happens, NSP14 will get abolished. So if we get a mutation of NSP14, this virus will become a highly mutable virus like a flu virus. Convalescent plasma, I have already said, there are so many mutations seen when patients were given convalescent plasma and converted into a viral resistance. There was 439 mutation has been seen, 541 mutation has been seen, and 501 mutation again has been seen. You can see 439 mutation is again in the RBM. So next mutation will come. So one of the area is 439 mutation, which will allow the virus to bypass monoclonal antibody drugs. And this 439 is in the RBM. So UK virus is looking for a RBM mutation, which will come from unnecessary and unwanted delayed use of plasma therapy. Remember, I'm talking about if you use plasma therapy early with high titer, everything is fine. But if you are giving plasma therapy late in the disease or with a very low titer, which is not sufficient to kill the virus, you may end up into one of the RBM resistance. One of the RBM, you may end up into that. And then America has already issued that lab tests, the following lab tests are becoming unreliable because of the UK strain, because of 6970 deletion. But it is also a blessing come disguise. It is a blessing come disguise because deletion of 6970, if you say S gene failure is also a sign. S gene failure is also a sign that this is a UK strain. So I want to acknowledge people who have contributed to this presentation. Myself, Dr. Ganguly, Dr. Ashok Ratan, Dr. N.K. Arora, Dr. Angelique Kodze, Dr. Pavitra Venkatagopalan, Dr. Navedita Gupta, Dr. Jayanti Shastri, Dr. Anita Chakravarti, Dr. J.M. Kaul, Dr. Vedpi Mishra, and Dr. Arastu. These are the people to whom I have listened, interacted before making my presentation on various, everyone I have interacted for 1 hour in various presentations, and I have taken the gist out of it. So my idea here is everybody is basically talking about is, are we heading for a disaster? The answer is yes. UK strain is like a CMAAO. 19 countries have gathered together. And if UK strain gathers couple of more mutations, which are already existing in the circulation, so any RBM mutation which comes from plasma or from a misuse of drug will become a disaster in the UK strain. As on today, the latest Pfizer has done a testing and they said that my vaccine is working on UK strain. Everybody is talking about my vaccine is working on UK strain, but they are forgetting that their vaccine should also work on the South African strain, because the South African strain is in the RBM. UK strain is not in the RBM. It is the RBM portion which will make the vaccine ineffective. So if the UK strain enters into a mutation in RBM, or if the South Africa acquires England, like a share market, you acquire a company, if that virus acquires this vaccine, we may end up into a problem. Therefore, it is the best time to use a vaccine. It is the best time to take a vaccine so that at least you can have some partial immunity before it is too late. I rest my arguments for discussions to the chair.
Thank you, President. Always enlightening to hear you present your presentation. Could we have a copy of that of the presentation available to us on the chat?
Yes, I will send it to you. I will send it to you separately because
Thank you.
I don't know how to put it on the chat, but I'll send it to you.
Thank you very much. Just to update everyone, on my side in Singapore, we are rolling out the Pfizer vaccine. As President has said, it is opportune to take the vaccine now because we don't know what will happen in the next few months, whether all these viruses will acquire each other and each other's mutations and make the vaccine less effective or not effective at all. So far, we're rolling out in Singapore. I'll be getting my vaccine next week on Wednesday. I've already got an appointment to do so.
So will they allow you to take a movie out of it?
Oh yeah. I'll take a selfie or
Make a 10 seconds or 30 seconds video.
Okay.
Yeah, your Prime Minister's video was up everywhere.
Yeah, that's right. So some things about the vaccine in Singapore, very interesting, just to update everyone. So the Pfizer vaccine reaches Singapore at -70. And to thaw it out, after we thaw it out, it stays in the fridge for 5 days. The Moderna is supposed to stay for about 30 days, but the Pfizer will stay for 5 days. So it's a logistical challenge. And it's 2 shots, so it's 3 weeks apart and plus 2 weeks for the antibodies to appear, 1 to 2 weeks for the antibody to appear. So it's a 5-week window. Now, what we are looking at is to vaccinate 5 million people in this city over a year. We need to do 33,000 a day estimated. Now, if there is no outbreak, it's fine. But if there's an outbreak, gathering 33,000 people in long queues will be a big problem. So these are some of the logistic challenges we're facing. One more interesting thing is that it is not mandatory in Singapore. So it's moral suasion. And of course, when your time comes, if you don't take the vaccine, you might get bumped to the back of the queue, which is 1 year later. And the house is not on fire in Singapore. So a lot of people are gaming it. That means, oh, you go first, we'll wait and see. The truth is, at the end of the day, we know the short-term effects in about 90 days, but the long-term effects, of course, there are still some unknowns. But I think we have no choice here in Singapore. So a lot of doctors, we feel that we actually have no choice because a lot of our patients and friends and relatives and acquaintances are looking at us to as an example. So these are some of the considerations we are facing here in Singapore. And because we are a small place with no hinterland, we need to open our economy quickly. So there is also added pressure to the whole event. So these are some of the considerations going on in Singapore with regards to the vaccine. As for the side effects, we are asking everybody to be observed for 30 minutes. I asked our Director of Medical Services. They say it will be probably administered in a resuscitation available setting. So it won't be like in a GP clinic. It has to be a place where there's resuscitation available. Resuscitation, the serious allergy risk is estimated at 1 in 100,000. So basically, so everybody's observed for about 30 minutes. So that adds to the logistic problem. So that's where we are right now.
I only want to ask one thing here, that CDC US has listed a number of side effects which needs to be informed.
Yes.
And one of them is MIS, multi-system inflammatory disease.
Yeah.
So that means they are expecting multi-system, that means they are expecting delayed complications also.
Yes, of course. So really, in reality, amongst the doctors ourselves, as we chat, all of us, of course, if we have the luxury of time, we would like to wait and take it later. But the truth is, we are in a situation where we really have no choice, if you think about it. Because all our patients, friends, relatives, each one, accountable to several thousand people, everybody's looking at you to lead by example, because it's not mandatory. So these are some of the issues that we're facing here in Singapore with regards to the vaccine in the last couple of weeks. So that's a little summary of what's happening in Singapore.
Alvin?
Yes, thank you very much, Mr. President. Your presentation is really excellent. Though I had joined a little bit late, but still I had, enjoyed the latter half of the presentation. So I had the clinical duties today, and so I'm so sorry that I missed the first part. And also last week's presentation, I had missed it. So I would be very grateful later on if you could also send the presentation to me. Thank you very much. For in Hong Kong, yeah, I really envy the situation in Singapore. I think the difference between Singapore and Hong Kong is that Singapore has a strong upper hand government, although some people are still dubious, but then the government could have the administration smooth and the logistics probably much better than that in Hong Kong. Hong Kong's government is weak, is always criticized by even the pro-establishment and the oppositional parties. And so I wonder whether the government could really roll out the mass vaccination program as expected. As the chair had said, it's in fact not easy to have the mass vaccination for 5 million people in Singapore. And it would take 33,000 vaccinations a day, and each have to wait for half an hour and have to explain the consent form and for them to sign. So I would be grateful, Chair, if you could also send me the consent form that you have had in Singapore. Yeah, because many doctors in Hong Kong are not like the doctors you had mentioned in Singapore. Most of the doctors really are dubious and want to wait for the the sequelae of the vaccinations in Europe and in America and see what happened then. And because as if we are all now in the joining the third phase trial or the post-marketing experiments. So some doctors could not see what Dr. Agawa had just mentioned. The point of that mutations in the virus could sooner or later make the vaccines available now ineffective or less effective. And at that time, it would be much more difficult to control. But of course, some scientists and some researchers in Hong Kong said that the design of the vaccines now, the mRNA vaccines, are easily modified according to them. That is, they could always produce the new form of the vaccines after mutations have occurred. So I don't know how practicable is that in reality, but that's what they said. So still, some of, say, for example, just keep it between you and me, even the president of the Hong Kong Medical Association said that he would not have the injection yet. So as you said, doctors need to be the example, but doctors also could have his own free choice. And because this is not mandatory, this is voluntary. So, but of course, in Hong Kong, I don't think we could have 5 million people vaccinated. Most people, to be most optimistic, might be 2 million only out of 7.5 million. Perhaps only 2 million would have the vaccination, and it's not easy because even 2 million, you need like Dr. Zhang, you had said, you need to have at least 20,000 injections a day. And all the doctors, nurses are so busy already now. And you have to, as you said, if even we have the choice of Sinovac, that is the traditional method, the killed virus. All right, that is perhaps simpler. And ordinary clinics could also give the vaccinations. But still, most of the doctors will still advise the government that resuscitation facilities should be available even in the GP clinic. And some doctors demand the government to provide the resuscitation facilities to the clinics if they participate in the vaccination programs. And this also give a challenge to the government in the logistics. So, but anyway, we will first give the vaccinations of Pfizer, because they are already ready to be used in Hong Kong in February. For Sinovac, because the latest data from the third phase in Brazil had just been available yesterday night. And so they still have to calculate the overall results of the third phase, if not even not peer review, because they only have one report from UAE perhaps, or Turkey. That was with a effectiveness of 91%. But that study in Brazil is about more than 10,000 participants in the third phase, and that yields only 78%. The third phase trial of Sinovac in Indonesia is not yet released. And so they have to have a combined results of the third phase altogether before they could publish it, and before it could be available to all the public, to the scientists and doctors in the world. So until then, the scientists and doctors in Hong Kong would not use Sinovac until they had the published third phase trial results, like the Oxford one and the Moderna or the Pfizer one. So only up till now, it's only the Pfizer would be available in Hong Kong. Although we had also ordered Sinovac, we had also ordered the AstraZeneca from UK, but they are not yet available. So in February, we would only have the vaccination from Pfizer. But this one is the one that most doctors and even the public would be skeptical, because it's a new mRNA vaccine, and many people are worried because it's the new one with no previous data. And then also many patriotic people, because of nationalistic concern, they have been criticizing the new vaccines from the USA. And they criticize whenever there are bad news or pseudo bad news about this new vaccine, they would exaggerate it. And so the public receive a lot of such noise, and many might be skeptical about vaccination by the Pfizer vaccine. So this life in Hong Kong. People are really affected by the rumors and sometimes fake news a lot. I don't know the situation in other countries, but in Hong Kong, I think the doctors and the scientists always have to fight off those fake news and the fallacies in those KOLs and the videos spreading around. Yeah, that's about in Hong Kong. Thank you, Dr. Guo, for providing us the insight today that the vaccine should be given early to prevent the effects of mutations on the effectiveness of the vaccines in the future.
With the permission of the chair, just want to add, beautiful discussion going on. Whenever there is a deletion, the previous vaccine should work. The reason being, you are only, they are already, deletion should not make a difference as far as the vaccine is concerned, but substitution may, that substitution may. Number two is, one thing I'm only peculiar, the virus originated from China. They have the best results so far because they have been able to control the disease much better than any other country. They have practically been able to control. They are the one who brought out the kill vaccine, and they are the one who are distributing to all over the world. They are the one who launched it in August. 6 months data is available. Why a country who has the largest antiviral program in Wuhan, best of the labs in Wuhan are not working on vector vaccines or mRNA vaccines. That is something which is puzzling me. Why Chinese group is not working, because they are the first one to duplicate any attempt from any other country, because both the vector vaccine as well as the mRNA vaccine is new. No other vaccines are available for the first time, and China is not trying to duplicate them. Any comments?
Mr. President, I think that China is not as scientifically advanced as the USA and UK and Germany. That's how I see it. In fact, the PLA? I mean the Liberation Army of China had partnered with Yunnan Valvex, and then a Suzhou sort of vaccine production and manufacturing team to research on the mRNA vaccine on the January 21st, on the December 21st, last month. That is, they announced that they will begin researching the mRNA and production of such a vaccine this year, and they would produce about what I mean is they would produce 120 million vaccines this year. They aim at that. So they are not researching it. They are not producing it because they are not yet ready last year, I think. So they are just ready now, and they are going to have the first and second phase of the trials. And then so after third phase trial, I think it would be not earlier than the end of this year to have the production of such mRNA vaccines. So I think they produce the killed vaccine first because it's easier for them to do so. But for the other countries, they had developed the mRNA vaccine against a spike protein. I think is, according to them, they said is faster, that they could develop this new vaccine. And then that's why they all did this first, and they did not try the killed vaccine for the other advanced nations in science technologies. I just wonder if Dr. Chong, you had heard about anything like that.
No, we haven't. I actually have a question for President. If the mutations, can it affect the Pfizer vaccine because of the spike protein? Any mutation would affect the spike protein significantly to negate the Pfizer vaccine? I'm just curious because I'm receiving it next week.
They are not talking about as yet about the South African. I'm only listening to, because I am concerned about the effect of the vaccine on South African strain. Angelique is here, she may be able to tell, because South African strain is more important than the UK strain. They all are talking about our vaccine will work on the UK strain, but they are not talking about whether it will work on a South African strain or not, because that is my concern. As on today, they say that South African strain has not reached any other country except one case in UK. So if this South African strain is going to affect the mRNA, I don't know. Because again and again, I'm more concerned about a strain which is carrying the RBM moiety part of the vaccine.
Yes. One more thing aside is just to let everyone know, because the Singapore government procured the vaccines and is distributing it free. I mean, it's not a commercial distribution. You know, it's all entirely done by the government and the machinery. So there is they've made it clear to everyone that there is no choice. If there is 2-3 vaccines available, there is no choice. You just take what you're assigned to. So there is something just to let everyone know that this is the thinking here.
In Dubai, they are giving a choice to the people that you want a Pfizer or you want a...
There's no choice. There's no choice because of the logistics.
Every country, it may be different. And
Yes.
because I got a call from Dubai that we have got we need to fill a form, which one we want.
Ah,
Every country they have a different thing. Let's listen to
Dr. Raghu,
after Angelique. Angelique, you want to say something that the latest situation in South Africa?
Thank you so much. And I also missed the first part, but it's always nice to log in and listen to you guys. I'm also learning a lot. As far as we know, they tested against 501, but not 501.V2. I'm not talking about the AstraZeneca one that we are now going to get into South Africa. So the question is still open and out there, exactly as what you all mentioned, whether the vaccine would be effective against the not 501, but 501.V2. And we do have a concern about that. But we are sitting in a situation, the moment when you go out and say to the public that you are worried, it means you will play into the hand of the anti-vaccines. And it becomes a very delicate balance as to your own concerns regarding vaccines and that of the broader public. So it is extremely difficult. Pfizer, there are indications that we are in negotiations with Pfizer, but as it has been said here, that we will have the same logistic problems. I just want to say, we are supposed to roll out, the vaccines is not yet into South Africa, but listening to you guys, the logistics, I think is going to be a nightmare. They still wanted to develop a IT platform system or an app where you can load on all the particulars of the patient and details and geographical information. But if the vaccine is going to be here within the next 2 or 3 weeks, I think we are going to be in trouble in South Africa with the rollout, with the logistics. It's not that easy. And listening here, we know that you have to wait half an hour, but it also raises a question, especially in South Africa, where are you going to put those people that needs to wait half an hour? And my other question is, how, if you already have the virus underlying, and I inject you, would I make you worse? Would you get sick? How are you just going to vaccinate each and every one if you've got antibodies already, if you had the virus before, or if you are currently asymptomatic? What is the implications? I don't know whether there's any answers on that. Thanks.
So what is happening is that when the virus enters my body, it produces two types of antibodies, neutralizing and non-neutralizing. Neutralizing antibodies will kill my body, will kill my new virus. But if I develop non-neutralizing antibodies, then it will basically attach, it will become convert a cell into antigen presenting cell, and which will produce cytokines to kill it. So there is a neutralizing antibodies and a non-neutralizing. We don't have any evidence about non-neutralizing antibodies as on today. Therefore, they are saying is that we must watch for MIS. Multi-system inflammatory disease is due to interaction of non-neutralizing antibodies with the new virus, precipitating a cytokine wave. That's what people are looking for. We have no answer for that. The RNA viruses and DNA viruses basically are more antigenic, more inflammatory in region. Therefore, you may get more MIS-like picture. But at the moment, why we are discussing this case is because we are trying to make a point that early vaccination is the answer before the virus mutates further. That's our hypothesis for which we started and debated that should we, because our concern is early vaccination is the answer. The way virus is behaving, this virus of the UK strain has to mutate further. There is no reason for it not to mutate. And it has to mutate further for two things: high transmissibility, and number two, non-actions of the drugs and the monoclonal antibodies and the vaccines. So therefore, this virus wants to become like a HCV virus, so as a chronicity in the body. So every virus would like to persist in the body for some time, won't like to be killed, and won't like to kill you. He wants to stay inside your body like Hep B and Hep C. So my assumption is the mutations are towards making it a chronic virus. Therefore, it is better to kill it now than to allow it to become a chronic virus. That's my hypothesis, assumption after reading extensively. Dr. Jamal.
Yeah, thank you so much. Actually, I had question actually this whether anybody is claiming any superiority. There's something mRNA vaccine producer over the vector carrying this virus vaccine. So, do you have any information about that so that the people will be attracted to the?
War. We
Yeah.
expect a vaccine war. I announced it a couple of months back also in the same forum. We expect a vaccine war. So there was a war between Oxford and Sputnik. I am better and you are worse. Then we saw it in India between Serum Institute and Bharat Biotech, claiming that I'm better, and somebody saying you are like only a water, there's no vaccine into it. And the other one is saying I'm more scientific than you. Unfortunately, Moderna and Pfizer are not fighting with each other. But when the DNA vaccine comes, the war is expected to accelerate. The DNA vaccine would say I'm better, RNA would say I'm better. That's expected.
I actually raised the question scientifically. If you can just think whether this mRNA is a new type, and whether the composition itself differs, and composition itself demand any superiority rather than the efficacy. What with the Moderna and Pfizer claiming over the AstraZeneca vaccine.
Let us see one thing, that both the vaccines available, even vector, we have no other example. Both the vaccine, vector, only one vector vaccine is available, that is dengue, which has not been very successful. Okay, so only vaccines which are not, these are the first vaccines. All the three vaccines which are available are produced for the first time. So we don't know long-term safety of any one of them. We don't know. Because what will happen, as on today, all the vaccines available, anything when you manufacture within a year has to be something different. Or it has to be a killed vaccine.
In matter of the allergic reactions or anaphylaxis, there's a US, I have seen the CDC.
All RNA viruses will be highly allergenic. They will be 10 times more allergy production than a non-RNA vaccine.
Yeah, they are expecting actually more than 3% actually, reactions, but they have got less actually. I have seen in the US that near about they are reporting near more than 10,000 and more than 20s. Yeah,
10 per million versus 1 per million in flu, 10 times than
yes. But they are getting less actually, which I have seen. I have compared. This is actually.
I'm only trying to add is the vaccine which we have never challenged, which is a killed vaccine, is a rabies vaccine. All rabies vaccines are killed vaccines. You can't take a chance of a rabies to produce a mRNA vaccine. So therefore, every company has chosen it to be the safest vaccine is a killed vaccine. So therefore, all those countries who are getting killed vaccines are as good. Of China, India, all killed vaccines are going to be as good.
True. Well said, President. President, you mentioned something just now about one per million versus 10 per million. What was that? I didn't catch that.
This is what you said, 1 per 100,000, which is 10 per million.
I see. Okay, so 1 per 100,000.
See, one per 1,000 is 10 per million. So with Moderna and Pfizer, you have 10 per million, and with flu, it is 1 per million. So it is 10 times the chances of getting a anaphylaxis compared to the flu vaccine.
Yes.
But it is due to the PAG they are claiming. This is the PAG.
Whatever it is, whatever.
Yeah, not due to mRNA or it's.
I said whatever it is, vaccine is a vaccine. So in Moderna and Pfizer, you also have one death. We don't know what the reason is. We also have severe allergic reactions. So RNA vaccines are supposed to be inflammatory. That's a known fact. That any mRNA, see, these vaccines were used basically for cancer. For the first time, they're being used for the healthy people. In a cancer, you don't see efficacy after 10 years because the average life of a cancer patient is 5 years. So efficacy of a mRNA in a cancer means, does it increase the lifespan by 5 years or not? So the first time it is being in the healthy people, only the next generation will decide about it, not this generation.
Mr. President, one more thing I would like to divert a little bit from the vaccine. I just like to promote vitamin D supplement campaign in the society. Do you have such similar vitamin D campaigns? Because we all know that vitamin D is so important now in the prevention and treatment of COVID-19 and improve the even the mortality rate and reduce the ICU usage. And in fact, the level of vitamin D is important to be kept, say, even above 20 nanogram per mil. So I just wonder, do you have such campaigns?
Yes, in India, we started when I was the Secretary General of IMA. So I started a campaign called IMA Rise and Shine.
Yes.
And that was basically rise. Rise means vitamin D rise in the sunlight.
Yes.
For vitamin D. So we started a campaign of IMA. IMA is Indian Medical Association, Rise and Shine. It has two meanings.
Excellent.
The rise and shine, it also has a vitamin D into it, that you make your vitamin D level rise, and then shine means sit in the sunlight. So we started a campaign, and then we started the concept of CMAs in sunlight. I launched at all your medical educational programs. Why do you need only in a hall? Why can't you have an open meeting on a sunlight? So in India, we have 85% of the people who are vitamin D deficient. Medical doctors are very highly deficient. So therefore, we talked about keep your vitamin D above 20. Vitamin D upregulates the ACE2 receptors and prevents the cytokine crisis in the lung damage. So that is well known. Vitamin D now is an essential part. We are calling about zinc, vitamin C, and vitamin D are essential part of the treatment.
Yes. So President, what about?
Yes, sorry. Alvin, sorry.
So I just wonder, because say Angelique is from South Africa, which is also away from the tropics or the equator. We have, say in Hong Kong recently, a cold winter and less sunshine. And of course, perhaps, I don't know whether Marie is here from Japan. So in our locations, we don't have so much sunshine in the winter. So I just wondered, are there similar campaigns, not just sunshine, but supplements or the vitamin D supplements in the countries away from the tropic, or in even?
So the recommendation in India is 60,000 per month, everybody.
Sorry, can I come in? I recently had this past week, we had a meeting with the vaccine committee. And you would not believe, but these scientists in South Africa sitting on this specific committee is very anti-vitamins. And, you know, in South Africa, the problem is the darker the skin, the less the absorption of the vitamin D. So we also have a huge vitamin D deficiency. For now, calciferol is unavailable in South Africa. And they even, when we, you know, they were of the opinion that when we treat the patients with coming in at cold phase level, that we should give them nothing. And I said, that's totally impossible. You have to come up with vitamin, you know, so calciferol, vitamin D, vitamin C, as well as zinc. And some of them were very unhappy with me. And I said, if you don't give a guideline to the patient, they are in any case going to use it out there. So let's give them a guideline where with a safety framework, so that at least you know that they use the right vitamins. For me, and so, you know, as a GP for more than 30 years, I understand the importance of vitamins, but it seems to me that some of the scientists lost the connectivity with the average person on the ground. And I think this is very dangerous. So we're trying to come up with a standardized type of protocol where we can guide and advise our GPs how to treat at first line, with patients that's not very sick. Thanks.
Yeah.
I'm actually very glad to hear about the vitamin D. So I'm going to use this as well as a part of my arguments this coming week.
Oh, that's great. In fact, there are many, many more scientific evidence published in the scientific journals about the effectiveness of vitamin D, the importance of it since COVID-19. For the past year, there are so many new papers. One very significant one is the Indian one published in the BMJ, and that had aroused many people's awareness about the importance of this age-old vitamin D, but in fact is really crucial in the prevention and management of COVID-19. And thank you, Dr. Aguao, for also enlightening us. Even last year, you have been saying about vitamin D and zinc.
Quick question for President. Sorry to just take it a little bit out of the another off track. Is there any validity to this ivermectin thing? I've been asked by so many of my patients recently.
See, ivermectin is a debatable drug we use extensively in India.
Yes.
And we have a protocol in one of the government state protocol where it has to be given. So ivermectin has been used both for prevention as well as for the treatment. It basically acts as an antiviral drug. It reduces the viral load. Therefore, its efficacy is early enough. Its anti-inflammatory role is doubtful. So if at all it has to be used, it has to be used as a stat dose on day one. And if you use it as a stat dose in day one, it will help in non-replicating the virus. So what we say is even doxycycline has an antiviral effect and anti-inflammatory effect. So all those viral drugs which have an antiviral effect has to be given on day one or day two to prevent those mutations. So therefore, ivermectin, there is a Bhubaneswar trial from All India Institute of Medical Sciences where they have seen that ivermectin prophylaxis has also reduced transmission rate among the healthcare providers by 87%.
By how many percent? Sorry?
87%.
87. Wow.
Percent prevention in those cases, but these are smaller studies. So there is a group which I wrote yesterday about ivermectin controversies. There is a group who says go for RCT. So the question, the debatable issue is, in pandemic, should we go for RCT or should we go for broader good? So there was a consensus statement which came that in a pandemic-like situation, if you hypothesize a drug which is not going to harm and may benefit, give it. So the pandemic answer was, if you have a hypothesis is you say this drug may work in RDRP, may work at this particular position. And if you are sure it is harmless, you have to be very clear. Then giving it makes sense without doing a randomized control trial. So say, for example, melatonin. Melatonin does not harm, may benefit because of its mechanism of actions, the way it is working. Therefore, giving it makes sense. But if you are not sure about a drug, say, for example, doxycycline, it's an antiviral, it's antibacterial, it's anti-protozoal, it's anti-malarial, it's anti-dengue. It's a drug which is broad spectrum, takes care of atypical fever, harmless, less chances of mutations. Because till today, doxycycline resistance is not well recognized. Therefore, the antibiotic to misuse is doxycycline compared to azithromycin. So azithromycin, if you misuse, you will end up into a resistance. So that's how you decide in the community in a pandemic-like situation. So you can't say in a pandemic-like situation, the person is dying, let him die. I don't want to experiment anything. So experiment cannot come with the randomized control trial. So there are 6 different types of methodology by which you decide how to treat. One is called pratyaksh. This is a Hindi words. Pratyaksh means that you are seeing something. You say that I saw this response. This becomes pratyaksh. Pratyaksh means observation. These are called observational studies. So if you observe something, that doesn't mean it will work in other state. This may not mean it will work in other country. You say, in my observation is helpful in deciding whether the disease is spreading or not. That is called pratyaksh. Second is anuman. Anuman is that you hypothesize a situation. You say, if H1 blocker, this H1 blocker, if this is a allergy, then H1 should work. H2 blocker should work. That is called as based on your hypothesis. And hypothesis is your RCT, randomized control trial and trials. Based on hypothesis, either you prove it or you disapprove it. Third is called upaman, which means analogy. Analogy is that you say this is how the virus enters. So any drug which takes care of ACE2 receptors, transmembrane place in RDRP should work. So that is called analogy. And the fourth is arthapati, which is circumstantial evidence. That is a circumstantial evidence. You decide on the basis of the circumstantial evidence, you decide arthapati. Then is anuplabdhi. Anuplabdhi is the story of negation. That I gave him 6 medicines. Another patient also gave 6 medicine. Only 1 medicine was common. So was it responsible for the effect? That is called the story of negation. And 7th is personal observation called case studies. These are not observations of a group. That is a personal observation. In this particular patient, this happened. I don't know. I'm only informing you my case reports. So based on these 6, in a pandemic, we have to use all 6 types of evidences, not only RCT. Simple observation. See, if you would have gone into the origin of coronavirus and you would have said the very first case, let me do a RCT. Before deciding whether this is a new virus or not, the situation would have gone. You started with an observation. So even that observation made the first 10 studies were all observations. And that created the history with that.
But Dr. Agarwal, don't you think that after so many months of this existence of this virus, if you say that we are just talking about the sample size, very small sample size, does it justify the use of this ivermectin in such way where the people?
I am not even advocating ivermectin. I am only saying is RCTs are not possible in a country like India, Bangladesh, in a country which is a huge load of the work. We are not tuned to go for RCT studies. We will still base on observations, personal observations with that. I know in India, we have a program of giving anti-helminthic twice in a year, giving 1 tablet of ivermectin stat. I'm not talking about giving it morning, evening for 3 days. 1 tablet of ivermectin, which is anti-helminthic, is not going to harm. If you believe, give it. If you don't believe, don't give it. That's what I'm trying to say. If you say, if you are giving famotidine, it is also working at the level of replication. So any one drug which you feel may stop the replication in the initial phases, it can be famotidine, it can be doxycycline, it can be ivermectin. But I say is as an analogy, one drug should be given to assist in giving an antiviral drug. Now let's understand favipiravir. What is the justification for giving it for 14 days when the virus is dead on 7th day? Favipiravir is say give it for 14 days. The virus is dead on 7th day. What is the justification? We don't have. Just because a RCT is available which says give it for 14 days, we are blindly following it. Now, favipiravir takes 3 days to act. So that means you are giving it for almost like 17 days. You are making more viruses as a mutant. Remdesivir, they say give it on 5th day. What is the idea of giving it on the 5th day? Because by 7th day, the virus is gone. If you want to give Favipiravir and Remdesivir, give it on the first day and stop it on 7th day. So what is the idea of giving Remdesivir for 10 days? You're only producing mutations. Just because there is an RCT available, they gave it for 10 days, has no value. So therefore,
but in
I'm
case of
coming. I'm coming is that it has to be based on your country decisions. In India, ICMR has not approved ivermectin. It is not a government protocol. It has been left to the people to decide. So it is not a WHO recommendation. It is not a ICMR recommendation.
Can I just ask you this? In case of severe and critical case, and those who are dying actually, they are telling that the virus remains up to the last day of his life.
Let me come back.
Yeah, that's in case of severe and critical cases.
I will explain in this case. The virus can remain alive for 120 days. This is what I showed in my slide. That in a immunocompromised patient, remember, immunocompetent people, the virus will die on day 7. In a immunocompromised people, the virus may stay alive up to 120 days as per the literature, where I showed you 10 mutations occurring in one person. In these situations, you have to be very careful in giving drugs which can cause viral resistance. So therefore, the recommendation is in a patient with severe pneumonia on ventilator, the virus may remain alive for 10 days, 20 days. CDC recommendation is 10 days for immunocompetent and 20 days for immunosuppressant. In those cases, if you give Remdesivir for 10 days, it is justifiable. It is justifiable. But the study does not talk about those cases. They are saying it as a routine. Every patient in an immunocompetent, if you give it for 10 days, you may end up into a problem. So if you are saying immunodeficient, severe cases on ventilator, where you presume that the RT-PCR is still positive with a very lower RT-CT value, I can understand. I'm talking about a routine treatment. People are starting Favipiravir on 10th day as a OPD cases. I can give you hundreds of examples where people are taking Favipiravir starting on day 10 as an OPD procedure. No, these are the cases you may end up into a problem. So good discussion, landed for 38 minutes, 28 minutes extra. Prakash, you want to add? Mari, you want to add? Otherwise, we'll close.
Yes, please. The quick answer about vitamin D. We don't have any campaign for vitamin D right now. And also, we are going to have a large scale of vaccination in February, the government says. And a friend of mine who is working in New York took vaccination once. And it was quite painful, but no harm, and other than local pain.
Anybody who will have vaccination, Mari, if you get a vaccination, if you get a pain and fever, you must dance and celebrate. The vaccine is working.
Okay. And he will have the next one next week, and he will report about how the vaccination goes. So I will waiting for the answer. Prakash, thank you very much for every week. Thank you.
Yeah, in fact, I agree. In fact, I think fever should not be listed as a side effect at all. It is a reaction to the vaccine. That is good. It's not a side effect.
Side benefit.
Thank you very much. I remember that. Thank you.
There is no other question. I just want to introduce you to Professor Bijon Mishra. He is our representative of the public in the society. Bijonji, this is our group at 9:30 meeting every week.
Yes, I had heard. I've been always hearing great things about you all, and especially through you. It is my privilege. I came in and the meeting was long, so I got to meet all of you. Very nice to meet all of you, and I'm very happy that all of you are so much involved and active to give advice, and the right kind of advice to the consumers and the patients, because they are all the time getting so confused with the media reports, with other public domain accessibility to information, that we in India, at least, we are very lucky to have Dr. Agarwal, who always gives us the right direction. And we go with whatever he tells us blindly, absolutely blindly, we follow him. So,
Thank you,
so,
Bijanji. So we have here Singapore, we have here Hong Kong, Bangladesh, Malaysia, South Africa, Nepal, and Japan participating.
I visited all these countries.
Okay. So
I have visited all the countries.
the chair
So
to
I'm so happy.
Chair to finally give the final remarks and close the meeting.
Thank you, President, and thank you all for attending this weekly meeting. It's always a pleasure to meet all of you, and especially to listen to President Agawa's presentations. He's done a tremendous amount of legwork to tell us exactly in a very simplistic manner what we expect out of this pandemic and the war that we're fighting. So I will keep all abreast of my experience next Wednesday on the 13th. And hopefully we'll have a video to show you all. I'll make sure I'm here for the next meeting. Otherwise, you will think that something has happened to me. So without much ado, thank you all again for attending this wonderful meeting. And it's always been, I've always looked forward to this meeting, although it was a festive season for the last 2 weekends and I couldn't make it. But I always look forward to these meetings and meeting all of you. And we look forward to our next meeting next Saturday. Thank you all, and Happy New Year to everybody. Happy New Year.
Thank you all. See you next week.
Don't worry and get vaccinated. Don't worry.
Yeah.
Yeah, if possible, get vaccinated. Yeah.
Okay. Thank you so much.
Thank you.
Okay.
Thank you.
Okay. Bye.
Thanks. Bye.